Yes,
Hello,
ma'am.
Dr. Mehta. Good morning, one and all. Am I audible?
Yes, ma'am.
Yes. My heartfelt thanks to Parul University for inviting me to this wonderful Physio Summit 2021. Always a pleasure to be associated with Parul University. Thank you, Bhavna Gadvi, Chaitali, and the team of Parul University for arranging and organizing and the cordiality in extending the invitation and thereby following the same. Talking about today's topic and the resource person, hip and knee partners in crime. My fascination has always been biomechanics. I have always mentioned that a good physiotherapist has to be first a good psychologist, and with the sound knowledge of biomechanics, no one can challenge him or her in taking care of rehabilitation process in to the fullest. Today's time, pandemic time, everyone with a sitting posture, long sitting hours, working from home, postural issues. This is what I feel maybe Dr. Mehta might be talking about today when she'll be talking about partners in crime, the hip and knee. So we have jeopardized our posture, and the main culprit in this is iliopsoas muscle, because the only muscle that connects spine with the legs. And the crime committed by both this hip and knee could be, we'll listen to her what she has to say. Low back pain, neck pain, of course, knee pain, and because of the lumbar plexus and the diaphragm insufficiency that could be developed, which can lead to respiratory ailments, visceral problem, indigestion problem, and above all, definitely as she is an expert in women's health, she may talk many aspects with the menopausal issues, pregnancy related issues that can come up because of these two partners. So let's hear today Dr. Snigdha Mehta, a renowned physiotherapist in Mumbai, and very glad to know also and express also that her clinic has been mentioned as one of the three best in Mumbai in 2019 and 2020. I'm quite associated with her since long, and we have communicated frequently on many aspects. She has been a certified McKenzie therapist. She is the only therapist I've come to know who has been appointed as a resource person in India in the field of physiotherapy in for obstetrics, women's health, pelvic dysfunctions, and bowel dysfunctions. And she has been offered scholarship also to for the courses that can be run in USA. So a very warm welcome to Dr. Snigdha Mehta, and feel proud to introduce you to her as she is into practice, a dedicated professional, and will be very glad to know what she has to share on this topic today. Over to you, Dr. Mehta.
Okay, thank you so much, Nilima ma'am, for that wonderful introduction. And it's always a pleasure to see you. And thank you so much for being here. Thank you so much, Parul University, and especially Dr. Bhavna and Chaitali for arranging this. It's wonderful to be here. And I always love to speak to the younger generation. And I can see a whole lot of students in the hall. I would really enjoy this talk. I hope you too enjoy it. I will do screen sharing now. Great. So I hope all of you can hear me and all of you can see me. Is that fine? Yes.
Yes.
Okay. Great. So yes, the topic today is hip and knee partners in crime, and as Dr. Nilima Patel said, it's a huge topic, and the treatment should always be holistic, and you have to take care of every part of your body which could lead to problems of the knee. Today, however, I'm going to focus, because of the shortness of time, we're going to focus on a small aspect of it. So we are going to talk about knee pain that occurs without any obvious trauma. We have seen such patients, all of us have seen such patients right from our first day of our college, of undergraduate days, knee patients walking in, and these are the patients who have not had any obvious trauma. So source of knee dysfunction could be the hip, the ankle foot complex, the pelvis, trunk, and as Dr. Nilima Patel said, all parts of the body. And hence, whenever we examine such a patient and treat such a patient, is very important to give attention to the source of the problem that is causing knee pain. But in today's presentation, I'm going to restrict it to a small area of the body, and we are going to focus on the relationship between the hip and the knee. And even more specifically, we are going to focus on the normal transverse or the rotational movement that occurs between the femur and the tibia, and what is the effect of this excessive rotational movement between the femur and the tibia, and how we can control this excessive or uncontrolled tibio-femoral rotation, which causes knee pain during our daily activities like walking, stair climbing, etc. And ultimately, of course, we have to resolve the knee pain. So we all know about the screw home mechanism. A screw home mechanism is a key element to knee stability, as we all know. And we know that in open kinetic chain, tibia rotates externally during extension and internally during flexion. And in closed kinetic chain, femur rotates internally during extension and externally during flexion. So during the gait cycle, the normal range of rotation at the tibio-femoral joint is about 10 to 15%. But when there is excessive rotation of the tibio-femoral joint, there's loss of stability, and the biomechanics, as Dr. Nilima Patel said, gets affected, and this leads to knee pain. This excessive rotation is named tibio-femoral rotation syndrome by a very famous, world-famous physiotherapist, Dr. Shirley Salmon, whom I had the opportunity to do advanced courses with. And this tibio-femoral rotation syndrome contributes to problems like patello-femoral pain, ITB, band friction syndrome, osteoarthritis of the knee, and ACL injuries. According to Shirley Salmon, the most common cause of non-traumatic knee pain is the tibio-femoral rotation syndrome, or the excessive rotation between the tibia and femur, and this could be accompanied with either with varus or with valgus. And the reason I've taken up this topic is that we often treat patients, but we sometimes do not notice this excessive rotation that's taking place in their day-to-day activities. So there's a lot of research on this tibio-femoral rotation causing problems in patient, and Salces and Perman have reported that uncontrolled tibio-femoral rotation was the largest predictor of patello-femoral pain. There's also been a lot of research on abnormal hip mechanics on the knee, and we have Dr. Christopher Powers, who has done immense research. And again, I had the opportunity of going to University of Southern California as an observer and spending a lot of time with him. And he has done a lot of research on influence of abnormal hip mechanics on knee injury. And he says that all the hip mechanics, if they are not proper, they can cause ACL tears, IT band syndrome, patello-femoral joint pain, and OA knee. This is a research that comes from Brazil, and it is done on patients with OA knee who have low strength in the hip muscles. And what they say is that strengthening these muscles around the hip joint help the patients of OA knee to decrease their pain. And this is from a physical therapy department from the Wichita University of USA, which talks about the understanding the interdependence between the hip and the knee joints in respect to functional activity, which is very important for us clinicians to remember. This is from the University of Stanford University, California, done on distance runners. And they found that patients having ITBS or iliotibial band syndrome have weaker hip muscles. And when compared to the unaffected leg, and when these muscles were strengthened, their pain decreased tremendously. So while treating our patients with knee pain, it is not only important to prescribe exercise in the sagittal plane, but also note and correct, if needed, the excessive tibio-femoral movement in the transverse plane. So what is the ideal alignment between, of the tibia in the transverse plane? If you draw a line from the center of the ankle to the second metatarsal, we call it the tibial line. And what is ideal is that the tibial line should be 10 degrees lateral to the sagittal plane. This is ideal as far as the alignment of the tibia is concerned. And what is the ideal alignment of femur in the transverse plane? Center of the knee or the patella should be vertically above the second metatarsal. If we look at from the back, ideally the hamstring insertion should look quite symmetrical when a person stands, if they do not have an excessive rotation at the tibiofemoral joint. So in this case, you see this girl standing viewed from the back, and you find that I've marked the hamstring insertions and they look pretty symmetrical, and and her tibia looks pretty symmetrical, and hence she probably does not have a tibiofemoral excessive rotation. Static postures, however, is only a window into the movement. It is merely a starting point for assessing movements. So we'll talk about movements now. So what's the ideal alignment of the lower limb in walking in the stance phase? Ideally, the center of the patella should be in line above the second metatarsal, and the tibial line and the sagittal line should have an angle of about 10 degrees. Checking in the partial squat position is extremely important, because this position has the same leg alignment as just prior to heel lift in normal gait. Hence, in this person, you see the alignment is pretty good. What are the malalignments between the femur and the tibia which are commonly seen? The first is the excessive medial rotation of the femur. In this patient, you see if you see the center of the patella, it is medial to the second metatarsal. Viewed from the back, the hamstrings, the lateral hamstrings especially, are hardly seen, especially on the right leg. And this is another way of knowing that the femur is probably medially rotated. The other problem of malalignment is excessive lateral rotation of tibia. In this case, you see in this picture that tibial line is more than 10 degrees lateral to the sagittal line, whereas her patella seemed to be pretty much in the correct position, or the femur. Lateral rotation of tibia can be viewed also from the back aspect in a person who in the swing phase. And if you see the left tibia, it is pretty symmetrical. But if you look at the right tibia, it is rotated laterally. This would indicate the foot position would indicate the position of the tibia in the swing phase. Similarly, in the toe off position, if you see this person, his foot is pretty symmetrical, but as soon as he goes into the mid swing phase, his foot rotates laterally, indicating that the tibia is probably rotating laterally. And lateral rotation of tibia can be checked even in this position. As she climbs up, you see the foot pointing out and as she climbs down, also the foot pointing out. So probably the tibia is rotated laterally in this position too. Modified Thomas test is a good way of making out whether the tibia is rotated and what is the cause of it. So if you see in the first picture, she is lying in the crook-lying position with the hip knee flexed. And we all know that the tensor fascia lata is a flexor, abductor, and internal rotator of the hip. And hence, in this position, her tibia do not seem to be, they seem to be in a perfectly normal position. But as soon as we did the Thomas test and we put her hip into extension and a slight adduction, her tibia rotated laterally, and which would indicate that her TFL-ITB is probably tight, and also it is stiff, and therefore it rotates the tibia laterally, indicated from her foot position. The third malalignment is the most common: excessive medial rotation of femur and compensatory excessive lateral rotation of tibia. So you can view this from behind too. As you see in this girl, unlike the first picture where there was only medial rotation earlier, what I showed you of the femur, here you see on the right leg especially, there's not only a medial rotation of the femur, but also a lateral rotation of the tibia as viewed from the position of her hamstrings and as viewed from the position of her foot. So let's take a case study of 19 years old Alka. She came to us with complaint of anteromedial pain in the right knee since 3 months, and she had pain on walking, stair climbing, descent, sit to stand, squatting, and at night while she was sleeping. She had been doing exercises for 1 month prescribed by somebody, and to strengthen her quadriceps and hamstrings. And she was also doing hamstring stretches, and she was doing active SLR, but there was no significant reduction in her knee pain. Alka had no history of trauma, no varus or valgus, no hyperextension of the knee. We've kept the case very simple and straightforward, purposely not taking too many aspects of the knee joint and hip joint. Radiographs showed no abnormality of the tibio-femoral joint nor of the patello-femoral joint. On examination, her ligament integrity was normal. There was no patella malalignment or no poor patellar tracking. She did not demonstrate excessive foot pronation nor excessive tibial rotation during single leg stance or gait assessment. Her gluteus maximus and median strength were 3 on 10, and her quadriceps was 4 on 10. We did do evaluation of a lot of more things, but for this, I want to keep it a little more brief. Sorry, her hamstring length was normal. So we needed to find out what was the reason after a month of exercise, why was she not getting better? And how could we reduce her pain and prevent recurrence? So let's look at some of the tests that we did. So first we did the alignment analysis in standing, and we found that the center of her right knee was medial to her second metatarsal, but her foot position was quite normal, indicating that there was probably a medial femoral rotation, but her tibia seemed to be pretty well aligned. And then we did movement analysis. On single leg stance, the center of the right knee shifted medially to the second metatarsal, and on walking, we found that there was excessive femoral medial rotation during early mid stance. Femur seems to just collapse into medial rotation as soon as weight was accepted on the knee. Same thing we notice about the ascending and descending of stairs. So in all her movement tests, Alka had normal tibial alignment, but excessive medial rotation of femur and reproduction of a knee pain. But the beauty of it was when we passively corrected the medial rotation manually in her functional activities like walking, stair climbing, there was a decrease of pain. It proved the fact that the medial rotation of the femur was the culprit. So the excessive medial rotation of femur could be a structural problem like femoral anteversion. You see these people walking with in toes, or an acquired problem because of two reasons: stiff internal rotators of femur or weak external rotators of femur. So let's find out. So we did the Craig test for anteversion, retroversion, and we found that that the greater trochanter was most prominent and superficial when her tibia was in this position, and definitely she was not anteverted. And if she was anteverted, her tibia would have been more than 15 degrees to her right. So the tibia, the femur would have been in more than 15 degrees of internal rotation. But in her case, she did not have a structural problem. So yes, her problem was acquired. So were the medial rotators of femur stiff, or were the lateral rotators of femur weak, or was it both? We did a modified Ober's test for finding out if the TFL-ITB band was stiff, because TFL is a very dominant hip flexor, and so we put her leg into adduction and external rotation, and we found she could hold the leg in that position. So definitely her TFL-ITB was not tight. Which are the lateral rotators of femur? We all know that gemelli, obturators, piriformis, and quadratus femoris are all lateral rotators, but also deep posterior gluteus medius and deep gluteus maximus are very powerful lateral rotators of the femur. So we did a test to find out the strength of a lateral rotators of the femur. We passively put her into hip extension, lateral rotation, and abduction. And we asked her to hold that position without support, and then slowly bring her leg down, and all the time keeping her spine and pelvis neutral. Alka could neither hold the position of external rotation, extension, and abduction, and nor could she control the eccentric rotation. Her leg just fell down. So Alka's excessive femoral rotation was not because of femoral anteversion, not because of stiff TFL-ITB. It was because the muscles that control the medial rotation of the hip or the lateral rotators were weak. This is our conclusion. So to summarize Alka's knee pain, the site of Alka's knee pain was the knee. The cause of her pain was excessive or uncontrolled medial rotation of femur. And the reason for this was weak lateral rotator of muscles of the femur. Now our task becomes very easy because we all know how to do strengthening exercises of the lateral rotator muscles of the femur. So not only did we do the exercises, but we did the McConnell taping to control the medial rotation of femur. We educated her in correct alignment because symptom producing activities are different from exercises that we do in the clinic. We corrected the correction of wrong sustained postures was equally important, and whether we needed to give a foot orthotics or not was a question we did not look at that moment. So what was the exercise program for the same lateral rotators that I just talked about? And what are some of the exercise we did? So we did hip extension with the knee bent at 90 degrees so that the hamstrings are not overactive, keeping the lumbar spine in a neutral position. This was one exercise. And then we did isometric strengthening of the gluteals with her hip in abducted and externally rotated position, pressing the heels together. Then we all are familiar with the clamshell exercise that we did for her, especially for the posterior gluteus medius. And then the hip external rotation in this position. It's necessary to do exercises in all positions. That's why we chose different positions for exercises. And then we, of course, did the band exercises with hip external rotation, resisted. The exercise dilemma. But we found that purely strengthening the muscles was not transitioning into her sit and stand and going up and down the stairs without pain. She still got her muscles were much better, but still she got pain when she did some of the daily activities. So we realized that it was equally important to integrate exercise with correct alignment into functional activities. So the first thing we did was we taped her for better proprioception and better alignment. She had difficulty in preventing medial rotation in her functional activities, and that is the reason we taped her. We did the McConnell taping. Again, I am privileged to have been trained by Jenny McConnell, an excellent teacher. And the intent of taping was to minimize the rotation of the tibio-femoral joint. I cannot forget one statement made by Jenny McConnell. She said that if you tape a person correctly, immediately you will feel at least 50% of the pain reducing. And that's exactly what happened with Alka. The moment we taped her so that her femur was stretched into external rotation and supported by tibia in the neutral position, her pain decreased by 50%. And then we tried the single leg stance and walking, and she was doing it much better. Then we started training her for walking, first with the tape on and then without the tape on. And every time she walked, she was instructed to tighten her buttock muscles at heel strike. This produced a powerful external rotation of the femur or minimize the medial rotation of the femur. And so the pain was decreasing now. Then we taught her how to do the single leg stance, tightening her external rotators of the hip, and her pain also reduced in this particular exercise. We also taught her sit to stand. Now, how did we teach her? We put a block between her feet so that her feet would remain in the correct position, and we gave her a tubing so that which she would stretch slightly, activating her external rotators of the hip while she stood and sat. And this made it much easier for her. We also taught her the side step-up exercise, maintaining the alignment of the lower limb. We taught her the lunge and instructed her to keep her knee in line with the second toe. We put her foot on a rotating disc, so she has to very consciously keep her knee in line with the second toe, and this helped her do a lunge much more easily. Same thing, we trained her with the staircase, maintaining the alignment of the hip, knee, and ankle. And we also did a popliteus exercise. Though she did not have external rotation of the tibia, popliteus is a very important stabilizer of the knee, of which we do not often talk about. So, but we all know that when the femur is medially rotated, there is a compensatory external rotation of the tibia. So to prevent that, we put her foot in the rotating disc and we stabilized the femur and asked her to do medial rotation at the tibia so that a popliteus action would be much better. Balance and proprioception exercises are also very important. So we taught her quite a few exercises on these unstable surfaces. Education, as we know, is very important part of physiotherapy treatment. So the correct alignment of the femur and tibia in all her daily activities at home was extremely important instruction. Alka did not need foot orthotics because she did not have excessive pronation of the foot. We had observed over a period of last so many days, and therefore we did not give her any foot orthotics. If she does have excessive pronation of the foot, then probably, and this excessive pronation of foot can lead to excessive femoral medial rotation, and then probably we would have thought of it, but she did not need it. There were some other factors that were contributing to her tibio-femoral rotation syndrome. Meckel and associates have said that 20 minutes in a sustained position can induce creep in soft tissues, requiring longer than 40 minutes for full recovery. So it was very important to change her sustained position. Alka had the habit of sitting cross-legged. Many of us have, not a good idea, especially girls and women. So what happens when we sit like that? We are constantly stretching all our abductors and external rotators of the hip. And when we stretch them for a long time, they do get attenuated. So we asked her to stop sitting like that. And also she had the habit of sleeping. Many of us sleep like this. So for the same reason, we corrected and we put her leg on a pillow so that her abductors and internal rotators were not stretched excessively the whole night. That's 1/3 of your 24 hours. So Alka's outcome at the end of 3 weeks, Alka had no pain. We were very relieved in all her daily activities, but her goal was to start running. So she continued to come to us for another 3 weeks till she could run without any pain. And I must say, Alka was very conscious about her exercises, and we had some wonderful results with her. There are some other contributing factors to this tibio-femoral rotation syndrome, which I have seen in my practice. One is this habit of sitting like this in amongst young children. Many of them sit like this at a very early age. Unless they have a structural problem, we should correct them. And these are the kind of people I have seen the activities itself are more likely to produce lateral rotation of tibia at a later age and ultimately lead to a tibio-femoral rotation syndrome. The ballet dancers. Many of the ballet dancers, they are told to externally put their foot pointing out, and therefore they develop an external rotation of the tibia and knee pain at a later date. While playing soccer, many children, they point the tibia outwards and point the foot outwards, keeping the knee or the patella in the normal alignment, and this could lead to knee pain in future. In horse riding, what you are instructed is you press your knee against the saddle, but your foot is pointing out, and this, if done over many years, especially starting from childhood, could also lead to tibio-femoral rotation syndrome in future. Skating is another activity, if done for years since childhood, can also lead to this problem. Breaststroke swimming also can lead to the problem of lateral rotation of tibia if done very often. So in this presentation, our focus was on how the hip and the knee have a very close relationship, how excessive rotation at the tibio-femoral joint requires a slightly different approach in evaluation and treatment of the knee. And what's my take-home message? To treat a patient successfully, first identify the site of the painful tissue. In this case, it was the knee. Diagnose the cause of the painful tissue. In this case, it was the tibio-femoral rotation syndrome. That is why exercises of stretching the hamstrings, active SLR, quadriceps were not making her much better. And it is extremely important to integrate exercises with the education of ADL, correct alignment during ADL, and correction of sustained postures. We forget that 1/3 of our time of 24 hours is spent in sleeping, and another 1/3 at least, so 2/3 of our time is spent in sustained postures, and that is why sustained postures could be the main reason why a patient doesn't get better. Wrong sustained positions. Yeah. So yes, so diagnosis, specific treatment should result in cessation of patient's pain and an improved ability to perform functional activities. I'm highly indebted to all my teachers and all the physiotherapists who are listening to me, but especially to Shirley Salmon, whom I've had the privilege to do advanced courses, Mark Comerford and Sarah Motram, who have done level 3 courses with, Christopher Powers, who I've spent a long time with, and Jenny McConnell. And all these people have been very great teachers, and they've all given me new eyes to see musculoskeletal problems. Thank you so much.
Thank you, Dr. Mehta. It was indeed an eye-opener, you can say. Very happy again to get a revision of biomechanics, the cause of knee pain. And it has been very rightly said, knee does not have a structural stability, but the knee is jammed between the hip and the foot. So if the alignment of the foot is proper, and if the muscles of the pelvic girdle, the hip are balanced and effective, knee is never going to suffer with any types of knee pains. So we all need to understand this. Whenever a person comes with a knee pain, we only focus on quadriceps and isometric quad setting and hamstring stretching. And most of the time, the foot and the hip are neglected, who are the real culprits for knee pain. Also very happy to know that you did not talk of any modality while taking care of your knee pain. This is I have been proud to be a teacher for 40 years, and definitely electrotherapy being our great subject. But let us not put the person on any type of modalities without proper assessment. Unless we assess, you cannot guide the person. I'm using the word guide rather than treatment, because when you say you guide a person, it is education, guideline, and therapy. And when you use the word therapy, it indicates the physical, mental, social, and spiritual dimension. Therapy, if you just go to the foundation of therapeutic exercise, the book that we refer has given a very nice definition of therapeutic exercise. It involves all the 4 dimensions. So it was indeed a wonderful presentation. And I'm sure these youngsters who are sitting over there believe in today's technology and believe in instrumental handling of the patient. They will again think of the marvelous role assessment can do, because every assessment is a treatment and every treatment is an assessment. We have to have this outlook for any types of aches and pains. And thank you once again, Dr. Snigdha. Always a pleasure
so
to listen
much.
to you. And indeed, a pleasure for everyone also to listen to what you had to convey in this hip and knee, the partners in crime. Thank you so much.
Okay, we are taking any questions or we are not?
No, ma'am. Hello.
Okay, yeah, okay, fine. Okay. Thank you
Thank
so
you,
much,
Snigdha, ma'am.
everybody.